Okay. A 27-year-old man comes to the physician because of 1 year history of pain and weakness and numbness in both arms and hands. Examination show weakness and atrophy of the muscles of the arms and the hands bilaterally. There is loss of sensation to pain and temperature over the neck, shoulders, and the upper extremity, but preservation of sensation to the light touch. Deep tendon reflex are absent in the upper extremity. Deep tendon reflex are absent in the upper extremity. He has thoracic kyphoscoliosis. Neurological examination of the lower extremity and the cranial nerve show no abnormality. Which of the following is most likely diagnosis?
That's crazy to see that.
Ready?
No, one moment. Mm, Between Frederick and Syringom. Yeah.
Thoracic kyphoscoliosis is specific for Frederick, isn't it? Syringomyelia does not cause kyphoscoliosis.
Oh,
Syringomyelia is cape-like distribution, uh, pain temperature lost in the upper extremity,
is
but
there any lower motor neuron in Syringomalia? Or it's just pain and temperature
pain and temperature.
only? Okay.
And thoracic kyphoscoliosis never happened in the Syrinx,
In the
as
same.
far I remember.
Okay, so it is. Oh my God,
We are wrong.
it's Syringomalia. It was. I knew it was because it was too much of a giveaway. They're gonna tell you thoracic of yourself. You're obviously gonna go with Fred. I was like, no, this is too easy. Mm-mm, just too easy. And does Frederick Ataksha has loss of sensation and all that? I don't think so. Oh,
Okay,
okay.
extremely sorry.
No, it's okay. It's okay. It's okay. No, that's I was between that also because of the kyphoscoliosis. I was like, okay.
So
This,
Syringomyelia can come with kyphoscoliosis.
I don't
Ve-
think so. I don't
Very
think. I think
absurd.
no. I think the guy just has kyphoscoliosis. It doesn't have anything to do with the
L-
silicosis.
like acquired, like
Yeah, like he just has it, whatever, and he just put it there too, but it doesn't have anything to. I'm thinking. Okay, let's read. This patient presenting with lower motor neuron pattern of dysfunction in the upper extremity. Okay, has syringomalia. Syringomalia features a progressively expanding cystic lesion involving the midline core structures. Syringomalia may be associated with congenital malformations such as Chiari malformation type 1. Okay. Spinal cord infections, autonomic disease, autoimmune disease like MS, neoplasm, and spinal cord trauma. Syringomalia typically damages spinothalamic fibers, okay, decusating in the anterior white commission. Consequently, patient present with deficit in pain and temperature, okay, that's what you say. In the bilateral upper extremities, okay, because of the ascending spinothalamic, whatever. Um, Sensation in the lower body is intact. The cystic lesion can expand into the bilateral anterior horns, location of the cell bodies of the lower motor neuron. The first patient may also present with lower motor neuron pattern in the bilateral upper extremities. Okay. Disease may also progressively expand to lateral corticospinal tract in severe cases, leading to upper motor neuron pattern also in the oh upper motor neuron pattern in the lower extremities.
is it Syringomyelia is like cord compression?
It looks like
Because
core
in the
compression.
upper extremity lower motor neuron sign, and in the
Yes,
lower extremity there is upper motor neuron sign.
yes, that's what they're saying, that it can be like core compression. Wait, Is there any sensation loss in core compression? There is, right? I don't remember.
There
Is
isn't.
there? There isn't. Okay, there isn't. Okay, so yeah, I guess syringomalia can present that core compression, but with sensation loss also. But usually it's like this. It's not they won't go until the lower body. They will just say it's the upper body. Most of the questions that I say is like this one, just the upper body.
Up, yes.
Mhm.
And they
Um,
are talking like cape-like distribution.
Cape like yeah, there's usually like upper body. They usually won't put lower body in it. Okay, but at least we know it's lower motor neuron and then sensation loss. Frederick ataxia is a genetic condition that presents with ataxia, spasticity, so upper motor neuron, and impaired speech, typically in young children and adolescents. It's associated with hypertrophic cardiomyopathy. So we'll need ataxia and upper motor neuron sign, not lower motor neuron.
There is an
Okay.
important clue that I missed actually. That is, like in syringomyelia, the classic presentation is pain and temperature loss with preserved vibratory and proprioceptive or touch sensation. In this patient, look at the second line, there is loss of pain temperature over the neck, shoulder, and upper extremity, but preservation of the sensation to the light touch. So, light touch, vibratory, proprioceptive, these sensation are preserved. This is a classic feature for syringomyelia. Then why thoracokyphoscoliosis? Thoracic kyphoscoliosis. Is it okay? So it is the main distractor in this question.
Yeah, it's just a distractor. Yeah, it's just a distractor. I wanted to read J thoracic outlet, but there is no, it's not here. And then cervical spondylosis, narrowing of the cervical canal, compression of the spinal cord, neck and shoulder pain, numbness and weakness of all extremity, gait instability, and weakness of the lower extremities with upper motor. That's what you were saying, upper motor neuron sign in the lower extremities. Okay, next.
So the main take home for syringomyelia is lower motor neuron sign in the upper extremity. Um,
So it's what you said, the cape-like distribution. Um, loss of pain and temperature, scapular distribution, and I guess lower motor neuron sign in upper extremities, I guess. Frederick Ataxia should come with that. Yeah, it didn't make sense because he doesn't have any issue with the lower extremities. Frederick Ataxia, at least you will see some kind of ataxia.
okay.
But next.
A 20, an 85-year-old man with eight an 85-year-old man with a 4-year history of ALS is evaluated in the ICU. Is evaluated in the ICU 3 weeks after admission for treatment of 3 weeks after admission of respiratory failure. Prior to admission, the patient has experienced progressive weakness ALS was diagnosed. Since ALS was diagnosed to the point where he was unable to swallow or speak. After admission to the ICU, He underwent tracheostomy and mechanical ventilation. Since admission, four attempts to wean the patient from the ventilator have failed. During today's evaluation, the patient is awake and remains unable to answer any questions correctly. He has little voluntary movement of the chest wall. Physical examination discloses diffuse atrophy, prominent fasciculation, marked weakness in all the extremity, and diffuse hyperreflexia. So physical examination: diffuse atrophy, prominent fasciculation, marked weakness in all extremity, and diffuse hyperreflexia. Prior to admission, he told his family that he did not want extreme measures utilized to keep him alive. The patient does not have a living will, but his daughter has medical durable power of attorney for the patient. Which of the following is the most appropriate recommendation for the physician to give his patient's family?
Don't know. Do we stop the ventilator or do we ask the daughter? Ask the daughter on discontinuation
Mm,
to make a decision on discontinuation. Okay.
mm,
Ready?
okay.
Okay. Ask the daughter to make a decision on discontinuation of care. This patient has expressed preference regarding end of life care prior to his current illness, but is currently incapacitated and unable to express a preference regarding his care. Options for directing care in a state of incapacity include durable power of attorney or advance directive, which enable patient to dictate the preferences of for end of life care ahead of time. Delegate responsibilities to a designated person. The power of attorney grants a particular person authority to act on the patient's behalf should the patient become incapacitated. This patient is currently incapacitated and therefore legal authority for this patient's healthcare decision making is held by power of attorney. Even this patient previously stated wishes and poor prognosis for recovery, it is reasonable to consider discontinuing care. This decision must ultimately be made by the patient designated power of attorney in this case. It is not the discontinuing the ventilator today is inappropriate without approval from the patient designated decision maker. Okay, next.
Okay. A 32-year-old woman comes to the physician. A 32-year-old woman comes to the physician because of 6 month history of daily generalized headache. Because of 6 month history of daily generalized headache, she occasionally has blurred vision. She occasionally has blurred vision in the right eye during a headache. Treatment with ibuprofen relieve the headache. She has had 23 kg weight gain, menstrual irregularity over the past year. Mens now occur at irregular 20 to 90 days. She is 168 centimeter tall, weight is 82 kg, BMI 29. Examination show a visual acuity 20 by 20. The visual fields are normal, optic discs are indistinct, spontaneous venous pulsation are not observed. The remainder of the neurologic examination shows no abnormality. Which of the following is most likely diagnosis? Venous.
Ready?
1 second. Okay.
Okay, so it is hepatic intracranial hypertension. IIH is primarily driven by impaired resorption of CSF. Signs of increased ICP include headache, nausea, vomiting, tinnitus, transient visual obscuration of blurry vision secondary to pressure on the optic nerve. Can occur examination finding include papilledema and increased opening pressure on lumbar puncture without any underlying pathology to cause such findings. Um, it is primarily found in young women who are overweight, although there is malignant cause of underlying although there is no malignant cause underlying the increased ICP. It may cause debilitating headaches, impairment in vision. Large headaches that are secondary to increased ICP often are worse when lying down and relief by standing. The most common risk factors for development and IIH include female sex obesity. However, hyperventapinosis A is another potential cause of IIH. This can cause from excess dietary intake or from use of retinoid medications such as isotretinoin or all-trans retinoic acid. Other medication associated with IH includes tetracycline, OCP, stanozol, and growth hormone. It's not E. Tension type headache typically presents with bilateral dull pressure like or pain-like pain across the frontal and temporal areas, often arising from stress. It does not present with postural headache, epilepsy, visual deficits, or other neurologic deficits. Okay, so in idiopathic intracranial is caused because of decreased reabsorption of CSF. So ICP is high. And then the normal pressure hydrocephalus is norm NPH, yeah, normal pressure,
And
whatever. And,
there is
and
ventriculomegaly.
there is ventriculomegaly and it's caused by
You are asking for risk factor.
no,
Eh,
like you remember here it says that it's caused by impaired absorption or whatever. But the normal pressure we read yesterday was caused by ah
See, on that normal pressure hydrocephalus. Oh, okay. I have got. You have talking about, is it what type of hydrocephalus, isn't it?
no, I'm saying that because here, okay, it says resorption of CSF is impaired. That's why the ICP there is increase in intracranial pressure, and it's causing all the symptoms, headache and whatever. But the normal pressure at the cephalus, there is a reason that is only normal pressure. Like if you do lumbar puncture, the opening pressure is not going to be high. And
Yes.
we looked we read the explanation yesterday. I forgot the question. But yeah, okay, okay, okay. Maybe we'll come back. Because I always get confused. I always get confused between those two. Okay. And the normal pressure is the one that comes with ataxia, he-
Ge
headache, and
yes.
issues with
Dementia.
oh,
Dementia, urinary incontinence, and there is gait apraxia.
okay,
Apraxic gait.
dementia, urinary incontinence, and ataxia. Okay, got it, got it. Next.
Okay. Okay, 1 second. In normal pressure hydrocephalus, CSF
Mm-hmm.
pressure elevated only episodically. It is written in the first state. It is a one sort of communicating hydrocephalus. I am
Mm-hmm.
sharing my screen. Okay, wait. Uh, okay, can you see my screen
Not yet.
now?
Not yet. Now, yeah.
Okay, look here. Hydrocephalus, communicating and non-communicating hydrocephalus. Normal pressure hydrocephalus, it affects the it is idiopathic. CSF pressure is elevated only episodically but does not result in increased subarachnoid space volume,
Mm-hmm.
and expansion of the ventricle distorts the fibers of the corner radiator, which will cause the triad gait apraxia cognitive dysfunction. You got my point.
Mm-hmm.
You were wanting this thing, isn't it? That
Mm-hmm.
CSA pressure is elevated or not. If they are talking about episodical elevation of the CSA pressure, then it is normal pressure hydrocephalus. Maybe.
Okay.
Okay.
Got it. Thank you.
Okay. A 7-year-old girl is brought to the physician by her mother dull generalized dull generalized headache for 2 days. During the past week, the patient has had difficulty walking and frequently has had loss of balance. So, difficulty walking and loss of balance. She has no history of serious illness. Her growth and development have been appropriate for age. Her temperature is 37, pulse 80 per minute, respiration 16 per minute, blood pressure 100 by 75 millimeter of mercury. Physical examination showed tilting of head to the left. There is marked horizontal nystagmus on the lateral gauge, bilateral marked horizontal nystagmus on lateral gauge, bilaterally visual field testing should know abnormality. Visual acuity is 20 by 20 finger nose testing and past pointing. Finger nose testing show past pointing bilaterally. There is an taxic gait. Is in towing. There is in towing of the left foot. Romberg sign is present. Which of the following is the most likely diagnosis?
Wait. Brainstem glioma. I have no idea.
Tilting of the head to the left. Uh, is it cerebellar lesion?
Uh, but why would they be rumbar sign would be positive?
That is, oh,
And then the headache. Why? Um, and the cerebellum is not even an option, an answer choice. Great vein of Galen aneurysm. What is the great vein of Galen? Brainstem glioma. Brainstem.
but
Between
only for 2 days. But there is dull headache also actually.
I'm between brainstem glioma and great vein of. I knew it's not craniopharyngioma because
It
something
comes
is
with like lactation problem.
right. Yeah. I mean, yeah. And then it's not meningitis. I think we know that. And then tumor of the vestibulocochlear cranial nerve. It will cause vestibular. Okay, maybe yeah. And it will cause cochlear. But he doesn't have any really ear issues. So I'm between brainstem glioma and great vein. Brainstem glioma. Brainstem glioma. I don't even know what is that. Okay, I'll go with it. Anyway, ready?
Yes.
Oh, now my pen is not working. Okay, there you go. So it is brainstem glioma. Oh, jeez. This patient with headache, ataxia, dysmetria, and nystagmus. Presentation of brainstem glioma. Gliomas are the most common pediatric brain tumors and are typically low-grade pilocytic astrocytoma. Pediatric gliomas commonly grow in the cerebellum. Oh, you were right. But can occur in the brainstem. Patients typically present with a focal neurologic deficit caused by mass effect that may progress over the course of months as a result of tumor growing larger and affecting additional brain regions. Treatment centers around radiation and chemo for breast and glioma. So, okay. It's not great vein of Galen aneurysm is a rare form of arteriovenous malformation that affects one of the intracranial veins. This may be diagnosed on fetal ultrasound or shortly after birth. Patients often present with signs and symptoms of heart failure. What? Okay. Okay, so seeing breast glioma symptoms, headache, ataxia, dysmetria, nystagmus, I guess. Okay, next.
Next,
Hmm.
a 70 a 71-year-old woman comes to the clinic because of 2-month history of increasingly severe aching pain in her shoulders, upper arm, thigh. She says, Uh, I cannot roll over in bed any longer, and my husband has to assist me in getting up from chair. She also has an associated she also has an associated muscle stiffness that lasts 1 hour every morning. Upon awakening, the same stiffness sometimes occur in the afternoon following period of inactivity. She also reports awakening multiple times during the night, diffuse joint pain, and 7.7 kg weight loss despite no change in the appetite. Menopause occur at age 56 years. She also has osteopenia, generalized anxiety disorder. Her medications are estradiol, escitalopram, vitamin D, and calcium supplementation. Her mother and aunt has rheumatoid arthritis, and her brother had sclerosing cholangitis. The patient appears to be in moderate discomfort. She is 5 feet 9 inch tall, weight 64 kg, BMI 21 kg per meter. The temperature is 36, pulse 68 per minute, respiration 18 per minute, blood pressure 124 by 76, muscle strength tone are normal. She is unable to actively abduct shoulder. She is unable to actively abduct the shoulders bilaterally past 90 degrees because of stiffness. Passive range of motion of the shoulders and the hip are decreased. There is no pain on palpation of the temporalis muscle. Hemoglobin 8.9, hematocrit 25, a leukocyte count 8,200, platelet count of 572, platelet count is high, ESR is high, CRP high, CK is normal or high?
Hi. Yes, sir. Hi too.
CK is high. Electromyography and nerve conduction study disclose no abnormal. Which of the following is the appropriate next step?
Ready?
Yes,
So it's prednisone therapy, polymyalgia rheumatica inflammatory condition characterized by proximal muscle joint, shoulder and hip pain, stiffness, and increased inflammatory markers, including if untreated, muscle weakness may occur from diffuse atrophy, Systemic symptoms such as fatigue are commonly noted. It's most common in patients over 60. Some patients have associated temporal arteritis. Signs of temporal arteritis such as throbbing, temporal headache, vision change, jaw calication should prompt temporal artery biopsy. The diagnosis PMR is based on clinical features and treatment is with prednisone for up to a year. It's common for patients to respond to prednisone almost immediately, thus the absence of response should prompt consideration of a different diagnosis. Next.
Okay,
Oh, sorry. I'm going to the next question.
next. Okay, I want to say about syringomyelia again. Syringomyelia, just correct me. Syringomyelia is a disorder where there is fluid filled cavity
Mm-hmm.
forms within the spinal cord, like fluid filled cavity, like syrinx within the spinal cord, isn't it? And
Mm-hmm.
usually it involves the cervical and thoracic area. C81 is the common involvement area. C81 level of the spinal cord. And in syringomyelia, there is loss of pain, temperature, sensation, uh, often cape-like distribution. Okay. And there is dorsal column is intact, so there is preservation of the vibration and proprioception. And there may be lower motor neuron sign, uh, as as syrinx can encroach into the anterior gray horn matter of the spinal cord. That's why there may be lower motor neurons, and as syrinx can encroach the anterior horn of the gray matter of the cervical spinal cord. And another thing, like in syringomyelia, scoliosis can occur due to paresis of the paravertebral muscle. So in syringomyelia, scoliosis can happen due to paresis of the paravertebral muscle, and it can also cause hyperreflexia, upper motor neurons, and when it affects the lateral corticospinal tract, it actually happens in the later stage of the disease when it mm, involves the lateral corticospinal tract, and it can also involve the autonomic fiber, which leads to incontinence and horner. And eventually, and finally, at the last, there may be loss of position vibration cells in syringomyelia. Okay. And is there any treatment of syringomyelia? I don't think so.
I don't think so.
Surgical intervention, maybe.
Oh, okay.
Surgical intervention can be done.
Okay.
Okay, next.
Okay. Next.
A 47-year-old man, lots of question come with 47-year-old. My roll number was 47 in the medical school. That's why I said so. Okay. A 47-year-old man comes to the physician because of pain of severe pain of the left eye and double vision that begin after a motor vehicle collision a week ago. At the time of the collision, he hit the head. He hit his head but did not lose consciousness. He did not seek medical attention at the time. Examination show exophthalmos chemosis and distension of the orbital periorbital veins of the left eye. A bruise heard over the left orbit. There is incomplete abduction of the left eye when looking to the left. Which of the following is the most likely diagnosis?
body.
1 second. What is your diagnosis? Is it herniation syndrome?
Herniation syndrome. I don't know what is that, but no, I don't think it's herniation syndrome.
Okay.
Oh, what happened? Wait, what happened? Oh. So it's carotid cavernous fistula. Carotid cavernous fistula results from an inappropriate connection between the carotid artery and cavernous sinus, often caused by head trauma. Aneurysmal rupture, inflammation, or vascular or connective tissue disease. Arterial pressure of the in the cavernous sinus hmm, okay, results in cranial nerve deficits involving those that transfer the cavernous sinus 346 V1 V2 as a result of extrinsic compression. Other findings can include vascular congestion of the ipsilateral of eye and face, exophthalmic chemosis, unilateral headache, eye pain, visual loss, and audible bruit on auscultation of the eye. CCFS or carotid cavernous fistula. Carotid cavernous, oh. Fistula can be categorized as low flow fistulas, which result from communication between the cavernous sinus and the cavernous arterial branches, or a high flow fistula, which result from a direct communication between the cavernous fistula and the vena carotid artery. Cerebral angiography, the gold standard diagnostic modality, will show flow through the fistula. Angiography. CT or MRI angiography may also be used. And treatment is endovascular intervention with embolization or stenting. Okay.
So how you diagnose this question?
I actually guessed, but I guess by deleting all the other ones. And I think yesterday we also had a question about like cavernous thrombosis or something. And I remember
Yes,
that it
cavernous
was,
sinus thrombosis.
yeah, we had a question, and I remember it was saying that cranial nerve 3, 4, 6, and V1, V2 will V1, V2 will be affected. So here, kind of 3 and 4 and 6 are affected, we know, but V1, V2, it's not really clear here. Um, but then the fistula, usually when there is fistula, there is bruit. That's
Brui.
also what clue. That also was a clue. And I know it wasn't infarction. You know it's not infarction because infarction is going to come with more stuff like hemiparesis and all these things. AV malformation doesn't really make well, I guess it makes sense. I guess I don't know.
It,
Epidural, you know it's not
yes.
epidural. You already know the signs of epidural. So barachnoid hemorrhage, you know it's not that will give signs of meningitis. So
There may
it's not.
be headache, sudden
But so
severe headache.
barachnoid, yeah, and so barachnoid gives you meningitis signs. So it's not there's nothing meningitis here. And subdural, you already know it's like old people and babies when they check and all these things. You know the yeah the symptoms. So it will be between AV malformation and carotid. I was between AV malformation and carotid cavernous fistula. But I went with carotid because of the signs, the cranial nerve 3, 4, whatever signs that they were giving you here. Let me read why it's not AV malformation. One moment. AV malformation describes an abnormal tangle of blood vessels located within the brain. Ruptured AV malformation may result in subarachnoid or intracerebral hemorrhage. Intracerebral hemorrhage appears as a dense collection of blood within the brain parenchyma. ICH often presents with focal neurologic deficit based on their location, with an associated headache and symptom of increased intracranial. Okay, so for AV malformation, it would be kind of like meningitis. So it's not that. Yeah.
Okay. After renovating a new home, a 41-year-old woman has burning pain and tingling in her right index, long ring fingers, particularly at night. The thinner remnants become atrophied. Which of the following structure is most likely damaged? Ready?
Yes.
Are you thinking any complex portion? Complex
No,
way?
no, I'm not gonna try to complex. Nope, nope. Mm-mm. It's median nerve. Carpal tunnel syndrome. So it shouldn't be too easy, but it shouldn't also be too complex.
Okay.
Car- Carpal tunnel
That one
syndrome.
is your best guess. Like you are in the right way, but I took you in the wrong way.
No, it should. But yeah, it's easy to get confused on that because then you started thinking, okay, everything. Don't overthink it. Don't overthink it. And then sometimes, yeah, you kind of have to overthink it a little bit. Just,
Now,
just.
uh, what we are thinking, we need to have some sort of justification before giving any answer.
Yes,
There may be a dilemma always in the real clinical picture also. On the the two clinician may have dilemma in their decision, but both should have some point what they are talking about,
yes.
and that both of them are right. Nobody is wrong actually.
Yeah. And I
Okay.
think you have to go with the diagnosis that has the most. Okay, this patient has two symptoms that go with this diagnosis, but he has three symptoms that go with the other diagnosis.
Yes.
It's probably the other one that has the three symptoms. Even
Yes.
if the one with two symptoms will still be, but it's only two symptoms that he has there. The other one has three. So I'm like, go with the one that has three, the more symptoms. I'm thinking that's also like a
Yes.
good thinking in that. Okay, carpal tunnel syndrome, CTS, compression of the median nerve within the carpal tunnel presents with signs and symptoms including pain, weakness, paresthesia, first three digits and the lateral half of the fourth, along with positive provocative maneuvers with no thinning and falling. Located, carpal tunnel located anterior to the carpal bones, sorry, the flexor tendons of the finger course through the tunnel, along with the median nerve. The space is rigid and does not generally permit compression. There's any inflammatory, traumatic, and space filling lesion may result in CT. Are you still there? Or did you hang
Yes.
up my call? Okay, okay. Patients generally present with pain and paresthesia in the median nerve distribution, along with weakness involving the muscles of the thenar eminence, and that may lead to atrophy. Symptoms are generally worse at night and relief with shaking of the hands. CTS frequently associated with pregnancy, hypothyroidism, rheumatoid arthritis, acromegaly, amyloidosis, Jesus. Ganglion cysts, obesity, trauma to the wrist, or chronic remodeling and scar formation following a wrist injury. Okay. Patients with mild symptoms can be treated with conservative wrist splinting. Wrist splints are typically worn at night, but may also be used during the day. Splinting reduces the range of motion of the wrist and limits activity that increases pressure on the carpal tunnel. Patients who have persistent or severe symptoms of muscular weakness may require surgical decompression. Okay,
Okay.
next.
Next. A 21-year-old woman is brought to the emergency department by her mother 1 year by her mother 1 hour after a 30-minute episode of generalized shaking. 1 week ago, the patient had a similar episode that began while she was at home watching television with her mother. At that time, the patient fell to the ground and had irregular jerking of the hands and the legs. During the episodes, her eyes were open and she was occasionally able to respond to the mother's comment. The episode lasts 10 minutes. The patient has had 15 similar episodes during the past week. She has no history of serious illness, takes no medication. She has smoked one pack of cigarettes for 6 years. She drinks 3 to 4 12 oz beers normal limit. Physical, neurologic, mental status examination disclosed no abnormality. CT scan of the head discloses no abnormality. During a video EEG, the patient has a typical seizure. There is no epileptiform EEG changes during the episode. Which of the following is the most appropriate next step in the management?
Ready?
1 second. Okay.
So it's CBT. Ooh, not see that one. Conversion disorder, also known as functional neurologic symptom disorder, involves neurologic symptoms such as sensory and motor dysfunction that are not fully explained by objective findings on physical or imaging. This patient is presenting with episode of generalized shaking and jerking during which she is able to respond to commands. A negative EEG likely indicates psychogenic non-epileptic seizure. Okay. A form of conversion disorder. Functional neurologic symptom disorder is postulated to represent the subconscious conversion of intolerable emotion into physical symptoms. Psychiatric comorbidities such as depression are common but not present in all patients. Physicians should conduct a thorough history and physical exam and obtain lab and imaging studies to evaluate for medical or neurologic disease that may explain the symptoms. Treatment of conversion disorder involves education about diagnosis, physical therapy, and CBT. It is not called saccharomyces, whatever, is an appropriate option for some patients with epileptic seizures. Anti-epileptic medication are not needed for patients with conversion disorder. Okay, next.
An 82-year-old man comes to the
I thought you were gonna. I thought you were gonna ask. I was waiting for you. Okay, okay, go, go.
even if I say I have to read the questions, so better read the question first. Okay. An 82-year-old man comes to the physician because of one day history of visual loss in the right eye. He has no eye pain, so painless vision loss. He has approximately 5 episodes of visual loss in the right eye over the past 3 weeks and lasts less than 1 hour. He has hypertension, hyperlipidemia, medical captopril, simvastatin. Mm, Corrected visual acuity is 20 by 40 on the left, limited to the hand motion on the right. There is prominent afferent pupillary defect. There is prominent afferent pupillary defect on the right in the right eye. Fundoscopy examinations. The right eye shown. Which of the following is the most likely diagnosis?
Oh, Jesus.
Vision comes and goes.
Don't know on this one. Hmm. Ready? Ready? Sorry.
Yes.
Okay. Okay. So is central retinal artery occlusion. This patient presenting signs and symptoms of abrupt, painless loss in pale fundus. Pale fundus, I guess. With normal fovea color are consistent with, where was the phobia again? Right here. Are consistent with a diagnosis of central retinal artery occlusion, CRAO. CRAO commonly occurs as a result of embolic occlusion of the central retinal artery, but may occur secondary to vasculitis, such as in the yeah. Patients may have history of preceding amaurosis fugax. Examination shows profound diminishment of visual acuity, relative efferent pupillary defect, and pale fundus with preserved fovea color. CRAO is a medical emergency as it's an ischemic stroke of the ophthalmic vasculature and indicates a high risk of associated ischemic stroke to the brain. Patients who present with CRAO should be admitted to a stroke center for emergent evaluation, including search for possible embolic source such as echo and Doppler ultrasound of the carotid. Careful history and lab evaluation of ESR, CRP, and platelets should be performed to evaluate for possible temporal arthritis. There is no proven medical or surgical therapy for CRAO, and the visual prognosis is poor. It's not age-related macular degeneration. It's an acquired retinal degeneration characterized by dysfunction of the retinal pigment, epithelium, and accumulation of macular drusen. Early stage of Early stage of the disease may be asymptomatic or characterized by insinus, blurring, and metamorphosia. In advanced stages, vision loss may result from retinal geographic atrophy or choroidal neovascularization with macular edema. Who is the macular? Is this one, right?
Sorry.
Macular degeneration. The macula is this one.
Isn't it the
Okay.
cherry red spot?
The cherry red. Oh, so it's this one.
Yeah, this one. Sorry. Yes.
Okay. So it's not E. Wait. Oh, they didn't put E. Never mind. Next.
Next question.
Mm-hmm.
Okay. Before jumping into this, I
Mm-hmm.
want to talk about central retinal artery occlusion and vein occlusion.
Mm-hmm.
Retinal artery occlusion, artery for embolism, and retinal vein occlusion is it is non-embolic, like thrombosis.
Mm-hmm.
And in central retinal artery occlusion, both has painless monocular vision loss. Painless in central retinal artery occlusion, painless monocular vision loss, and in central retinal vein occlusion also painless. Usually painless. There might be painful also, but usually painless painless monocular vision loss. History of amaurosis fugax can happen in both artery occlusion and vein occlusion, but artery occlusion is more common, and the RAPD, relative afferent pupillary defect. RAPD found in syphilis, isn't it? When RAPD is significant.
When
Reflex
mm,
lost. Relative afferent pupillary reflex is significant for which disease? Is there anything like that?
I mean, what do you mean is significant? Because it says
Like
that for
in the syphilis, relative apparent pupillary defect is found or not? That's the thing I want to know.
even if it's found, I don't think it's that
Okay,
important.
leave it.
Mhm.
Okay. In central retinal artery occlusion, there is a retinal whitening cherry red spot on the
Mhm.
macula, and In central retinal vein occlusion, there may be blood and thunder appearance.
Mm-hmm.
Blood and thunder appearance, and there may be diffuse hemorrhage, and there may be disc swelling, cotton wool spot. Okay. A 47-year-old woman is brought to the emergency department by her husband 45 minutes after sudden onset severe headache. She has 25-year history of occasional throbbing headache. The headache once or twice annually and are associated with nausea and vomiting and relieved with sleep. She has hypertension treated with enalapril. On arrival, she can answer questions. On arrival, she can answer questions but is intermittently listless and agitated. Her temperature is 37 degrees Celsius, blood pressure is 120 per minute, respiration 24 per minute, blood pressure 154 by 96. On examination, the left pupil is larger than the right, left pupil is larger than the right, left eye deviates slightly downwards and outwards, left eye slightly downwards and outwards. The patient resists flexion of the neck, exhibiting pain when the neck is flexed. Muscle tone in the right upper and the lower extremity is increased. Deep tendon reflex on the right side is increased. Deep tendon reflex on the right side is increased. Babinski sign is present on the right. Which of the following is the most likely diagnosis? People left deviates, Gardner, people down and out. Gardner palsy. No. Mm.
Mm-mm-mm.
Oh, the left eye deviates down and out. Isn't it Gardner palsy?
Third nerve, I don't know
Muscle
what's that.
tone, dependent replace rats.
She has kind of meningitis, but without the fever. Mm. And then she has like a bunch of signs of like upper motor neuron signs. Don't know. Okay, ready?
Wait 1 second. Okay.
Okay. So is rupture circular aneurysm. Rupture intracerebral aneurysm is the most common cause of non-traumatic subarachnoid hemorrhage. Circular intracerebral aneurysm typically occur at bifurcation in the circle of Willis, most commonly at the site of ACOM. Aneurysm can also be associated with hereditary disease such as ehlers-Danlos and autosomal ADPKD. This patient presents in a non-traumatic altered mental state with findings concerning for increase in intracranial pressure with herniation. This patient focal neurologic findings and asymmetric pupils are concerning for possible transsectorial herniation. SAH, subarachnoid hemorrhage, results from bleeding into the subarachnoid space. Patients may present with acute severe headache, stupor, coma. Blood in the subarachnoid space irritates the meninge, leading to rigidity. CT scan of the head shows hyperdense blood products in the cerebral sulci and basal system. As the blood product circulates within the subarachnoid space, complications include the development of communicating hydrocephalus in the acute stage, along with rebleeding and vasospasm in the week following the initial bleed. It's not carotid artery dissection with embolization can lead to focal neurologic deficits such as with acute ischemic stroke and upper motor neuron signs such as increase. We know that. However, it would be unlikely to cause nuchal rigidity. Okay. Uncontrolled hypertension can lead to intracranial hemorrhage, which presents with a progressively worsening headache and focal neurologic deficits. Hypertension leads to intraparenchymal hemorrhage, typically in the basal ganglia, cerebellum, thalamus. Um, yeah, and pons. Nuchal rigidity will be unlikely. Mm. In this patient, blood pressure discloses mild, not severe hypertension. Okay. It's not while patients with meningoencephalitis often present with acute headache and neck stiffness, the absence of fever makes it unlikely. Pupil asymmetry is concerned for increased intracranial pressure and herniation, which will be unlikely in meningoencephalitis. Okay.
Next, a 47-year-old man. A 47-year-old man has to quit his job as an automobile mechanic because of hand weakness and unsteadiness. He has bilateral wrist drop and upper limb ataxia. Lab studies show hematocrit 34, MCB 76, serum creatinine 2. Chronic exposure to the following is most likely explanation of this finding. Okay.
Okay, ready.
Yes.
Um, oh, my thing no more. Lead. Symptoms of acute lead poisoning occur within days or weeks of exposure and include abdominal pain, constipation, arthralgias, myalgias, muscle weakness, excessive fatigue, headache, difficulty concentrating. Prolonged exposure, chronic neurologic symptoms such as decline in cognition, depression, distal motor neuropathy, decreased hearing, tremor, and decreased brain volume and imaging may present. The distal motor neuropathy causes lower motor neuron signs such as atrophy and muscle hyporeflexia, as found in this patient. Microcytic anemia is also common since late is, we know that, or whatever, blah, blah, blah. Late in the heme synthesis. In adults, exposure to lead primarily comes through occupation and hobbies. Individual working with batteries, mining, construction, ammunition are high risk. Diagnosis is suspected based on exposure and symptom and is confirmed with increased serum lead concentration. Management of lead poisoning depends on the blood lead concentration and presence of symptoms and includes chelation with dimercaprol, ethylene diamine, EDTA, or succimer. Sources of lead should be investigated and eliminated. Oh, let me read the other ones. I never. Arsenic poisoning is uncommon and can cause dermatitis, skin cancer, neuropathy, hepatotoxicity, and in severe cases, systemic toxicity and death. Acute large exposure to arsenic can cause GI distress, kidney prolongation that may progress to dorsal point, cardiac arrhythmia, shock, and respiratory distress. So arsenic, skin, hepato, neurologic, and heart issues. Cadmium poisoning may occur in the industrial setting among co-workers involved in electroplating, metallurgical industry, and battery production. So typically occurs via inhalation and presents with fever, chills, myalgia, chest pain, cough, shortness of breath, pneumonitis, and pulmonary edema. So cadmium, pulmonary issues, and fever. Mercury poisoning may occur in industrial setting among workers involved in the manufacture of thermometers, mirrors, fluorescent lighting, and gold. Patients present with headache, ataxia, tremor, hearing vision loss, insomnia, peripheral neuropathy, and paresthesia. I don't know how to summarize this one, but yeah, we get it. And thallium poisoning may occur through transcutaneous exposure or via inhalation or ingestion. Thallium was previously widely used as a rodenticide, so pesticide, but thallium poisoning is now rare in the developed country. Though it's still used in the manufacture of semiconductor or whatever. Acute exposure presents with abdominal pain, nausea, vomiting, while chronic exposures present with neurologic and psych symptoms, headache, abdomen, anxiety, psychosis, ataxia, painful peripheral neuropathy, and distal weakness. So thallium, psych symptoms, GI symptoms, and peripheral neuropathy. Okay, next.
Okay. A 27-year-old woman comes to the physician because of one day history of difficulty speaking and moving. 7 days ago, she began a course of mitozentron and high doses of mitozentron and high doses cytarabine for recurrence of AML. She has been lethargic and mildly confused for the past 24 hours. She is 140 centimeter tall and weight is 47 kg, BMI 24, temperature 37, pulse 72, respirations are 14 per minute. Blood pressure 110 by 70, examination shows nystagmus and ataxic eye movement. Nystagmus and ataxic eye movement, muscle strength is full, and there is marked ataxia in all extremities. There is marked ataxia in all extremities. She is unable to maintain her balance sitting and standing unsupported. She is somnolent but can respond appropriately to questions and the instruction. Her speech is irregular in rate and volume. Language functions and the memory are normal. She can calculate well and her abstract reasoning is intact. Which of the following is the most likely diagnosis?
Ready?
1 second.
Mhm.
Okay.
So it's drug toxicity, acute onset neurologic finding in the setting of recent chemo are concerning for drug toxicity, specifically nystagmus, ataxia, impaired coordination, postural instability, dysarthria, or other speech anomaly in the setting of intact strength and higher cognitive functions are indicative of cerebellar dysfunction. Cytarabine, pyrimidine analog, can cause loss of Purkinje cells in the cerebellum. Okay. Leading to acute cerebellar syndrome. Risk factors include underlying neurologic dysfunction and impaired hepatic or renal function. Patients who present with acute cerebellar syndrome should discontinue cytarabine immediately. Some may experience permanent deficit, while others may experience spontaneous resolution. Okay. Next.
Okay. A 67-year-old woman. A 67-year-old woman with a 15-year history of Parkinson's disease comes to the office because of increasing involuntary movements over the past 2 years. She also has had nausea from her medication regimen, carbidopa, levodopa, and ropinirole, and attempts at medication adjustment have not been successful. She also has long-term history of cervical and lumbar. She also has a long-term history of cervical and lumbar stenosis, treated with diclofenac and physical therapy. Her pulse is 70 per minute, blood pressure 110 by 60. While sitting, pulse is 75 per minute, blood pressure 80 by 50 while standing, 110 by 60 while sitting, 80 by 50 while standing orthostatic. Okay, her speech is barely audible. Examination shows constant breathing, movement of the mouth, neck, and limbs. She walks with her neck flexed and takes small step with a decreased arm swing. Mm, Mental status shows the abnormal. Which of the following is the most appropriate surgical treatment?
Hmm.
Fix.
Mm, 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 mm. I don't know.
What is your diagnosis?
I don't know. I thought it was something with the medication for Parkinson, but it seems like it's not.
There is orthosis. Like, is it like autonomic failure? Is it
Okay, so you.
multi-system atrophy? Uh, I am thinking about Parkinson plus. I am
Oh,
trying
you
to.
have Parkinson. Okay, okay, okay. You think?
Parkinson plus actually fits with the symptom. Even
Okay,
if it is Parkinson plus, what we will do?
that's what I was.
We know that in Parkinson disease we can give deep, deep brain stimulation, isn't it?
Oh, okay, okay, okay.
Mm,
I have no idea on this one. I thought
okay,
the issue was. Yeah.
let's see. Pick
Let's
something.
see. Okay, so it's palidotomy. I just literally guessed. I don't even know what palidotomy means. Parkinson's disease is a progressive neurodegenerative disorder caused by degradation of the dopamine neurons in the substance and we know that. Symptoms are associated with imbalance of dopamine acetylcholine, resulting in characteristic findings of bradykinesia, resting tremor, muscle rigidity, postural instability, psych disturbances, sleep disorders. Dementia are common complications in addition to prominent motor symptoms. Initial pharmacotherapy, Parkinson's consists of carbidopa, levodopa, and other dopamine agonists such as pramipexole or pinorol. Patients who develop severe disabling motor symptoms refractory to medication and physical therapy may be considered for device-assisted therapies and invasive lesioning procedures. Device-assisted therapy include deep brain stimulation, invasive lesioning procedures are more common for patients who do not have access to device assisted therapies and cannot afford them. In unilateral pallidotomy, which targets the internal globus pallidus to reduce inhibitory signaling, is an effective treatment for improving refractory tremor, bradykinesia, dyskinesia, chorea, and gait imbalance. Thalamus and subthalamic nucleus are alternative targets for lesioning procedures. So I guess shut down the globus pallidus. Um, what was the another thing that I was confused? Oh, anterior temporal lobectomy is an effective surgical treatment for patients with intractable temporal lobe epilepsy. It will not help in Parkinson's. Okay, okay, okay. I think that was my only. Yeah, that's it. Next.
So anterior temporal lobe lobectomy for temporal lobe epilepsy.
Yes.
So everything has surgery.
This is the first time I never heard that you do surgery for
Truly,
Parkinson's.
the Parkinson. I heard about the deep brain stimulation
I
therapy,
have
but
no.
pallidotomy, I don't
I didn't
know.
even know you could do surgery for Park. Usually, the question is like the medicine is causing the issue. What do you do? Reduce the medicine or stop the medicine? That's usually what it is.
Yes.
Yes.
Okay, next. A previously healthy 37-year-old man is brought to the physician by his wife because of bizarre behavior for 2 days. He is very excitable and jumps when surprised. He is very excitable and jumps when surprised. His wife says that he has been experiencing visual hallucination. He refuses to drink liquid. He drink liquid for the 3 days prior to this behavior. He has headache, sleepiness. 2 months ago, he returned from a hunting trip in the mountains Temperature is 104. Examination shows inability to accurately answer questions and unusual behavior such as picking at the ear. He seems unable to swallow secretion and he is drooling. Acidity of the brain show no abnormalities. CSF show glucose uh, slightly high, maybe normal. Protein
Yeah,
is normal, isn't it?
it's high.
Protein is high, leukocyte count 150, erythrocyte count none, which of the most likely causal organism. Is it rabies?
Kind of sounds like
Because
enterophobia.
he is unable to swallow secretion, drooling
Mm,
like dog.
Systemic arbovirus. Yeah. Yeah. I don't know if rabies has visual. Yeah. It's rabies because not he don't want to drink liquids. Yeah.
Yes, hydrophobia.
Yeah. I guess rabies also has the hallucination. I didn't know. Okay. Let's see. It's rabies. This patient presents with headache and sleepiness and has progressed to hallucination, hydrophobia, drooling, and fevers, which is suggestive of rabies. Rabies virus is negative sense, single-stranded, non-segmented RNA virus belonging to rhabdoviruses. Virus is transmitted to direct contact with saliva of an infected animal. In the U.S., transmission occurs most from a bite from a bat, raccoon, or skunk, but in third world countries, transmission via dog bites is common. The virus has a long incubation period of weeks to months before symptom onset. It binds to acetylcholine receptors in the peripheral nerves and travels up the axon in a retrograde fashion to the central nervous system. Initial symptoms include headache, fever, malaise, but rapidly progresses to agitation, photophobia, hydrophobia, and hypersalivation. Once symptoms are present, rabies is almost fatal. For this reason, persons who are bit by an animal at high risk for carrying rabies should seek immediate care. Copious irrigation of the wound followed by intramuscular administration of kill vaccine is standard care. If the patient has not been previously vaccinated, rabies IG should be also be given locally into the wound. Okay, and it's not they don't even show the other questions anymore. The other answer. Arboviral refers to a group of viruses that are transmitted by arthropods, like tick and mosquitoes. West Nile virus is an example. It presents in patients typically present with fever, headache, myalgia, nausea, vomiting, non-specific rash, maculopapular rash distributed symmetrically over the extremities and trunk. Meningoencephalitis associated with acute flaccid palliatis, myoclonus, and okay, never mind. Next.
Next. A 17-year-old boy with a sickle cell disease is brought to the clinic. His sickle cell disease is brought to the clinic by his father because of 4-week history of progressive right hip pain. Progressive right hip pain. Initially, the pain was intermittent, and the patient rated it as 5 on a 10-point scale. During the past 2 weeks, it has become constant, and he now rates the pain 9 on a 10-point scale. The pain is not worsened by sneezing, coughing, or lifting objects. He was diagnosed with sickle cell disease at age 3 years. His disease course has been complicated by frequent bouts of dactylitis and pneumonia. He has had 2 blood transfusions done 9 and 6 years ago, respectively. He has been taking acetaminophen for hip pain, but it has provided minimum relief. Mm, Family history is remarkable for sickle cell disease in his mother, brother, and 2 sisters. For sickle cell trait in his father, the patient appears to be in moderate distress. Temperature is 36 degrees Celsius, pulse 98 per minute, respiration 20 per minute, blood pressure 114 by 68. Physical examination shows a decreased range of motion of the hip flexion and abduction. There is no pain on palpation on the lateral aspect of the hip. Muscle strength is 5 out of 5 throughout. Muscle tone is symmetric. Deep tendon reflex is 1 plus. In the lower extremity, bilateral sensation to pinprick is normal. Over the lower extremity, hemoglobin 9.8, hematocrit 28, leukocyte count 720. Okay, platelet count normal, ESR normal, CRP zero point 0.2. Which of the following is the most likely cause of this patient's pain?
Ready?
1 second. Okay.
What did you pick? Vascular necrosis or osteoarthritis?
Is it in in avascular necrosis? Deep tendon reflex is 1 plus. In the lower extremity bilateral, why deep tendon reflex is lost?
So you think is wait, you think is what? You think is
Uh,
you
it
think
may
is
it may be avascular necrosis.
oh
You are thinking about avascular necrosis.
I was between a vascular necrosis and osteoarthritis.
It
Okay.
is not the age of the osteoarthritis. Osteoarthritis it will never gonna happen in this age.
Okay. Okay. Let's check.
Avascular necrosis has possibility hip flexion and abduction.
Okay. Yeah, you're right. It's a vascular necrosis.
But
A
why
vascular
deep tendon reflex is low? That is my question.
hmm. Vascular necrosis or osteonecrosis results from impaired vascular supply to the bone with painful degeneration and loss of structural integrity over time. Decreased blood flow may result from direct injury to the blood vessel, compression by extrinsic structure, inflammation, venous occlusion, thromboembolism. In sickle cell disease, bone ischemia is the result of occlusion of blood vessels within the femoral head. Symptoms include pain, decreased range of motion, and difficulty with ambulation. X-ray may show stenosis changes, but MRI is the gold standard. Treatment requires adequate pain control, consultation with orthopedic surgeon, and physical therapy to preserve joint function. Arthroplasty may be considered in severe cases. They are not giving us the other answers. But you thought it was what?
I thought it was radiculopathy, but
L2.
L2.
Radiculopathy will lead to pain, numbness, and tingling in the L2 distribution. What is the L2 again? I forgot. Which travels from the lateral to medial thigh.
Hi.
Yeah, no, that's the thigh. We are in the no. While pain may present in a similar location, there will be muscle weakness of the quadricep muscles in L2 radiculopathy, and pain will not likely be present with range of motion or weight bearing. Yeah, with L2, you'll see muscle pain on top of the skin skin
Yes,
issues. On top of the skin.
there should have pain over the
Mhm.
dermatomal like L2 region.
Yeah, 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 yeah. And then I feel the deep tendon reflex
I
1 plus.
is it normal? I don't think so.
It's not normal. It's not normal. Normal is 2 plus. But I think that's the lower extremities. But here they're talking about the hip. I feel like the deep timber is the patella and the ankle, right? But here they're talking about the hip.
Yes,
Yeah. He probably has something else. It's probably like a distractor, I think. I'm thinking. The deep tendon thingy. It's like a distractor.
yes, deep tendon is a destructor. I was a bit confused about because for avascular necrosis or osteonecrosis of the this area, there is restricted hip abduction and internal rotation. They have said there is decreased range of motion of hip flexion and abduction. So hip flexion and abduction is okay. I don't know why I am choosing bad
I think you
answers.
try to, you try to overthink it.
Sorry,
You try to overthink this one.
I try to overthink plenty of questions.
This why you try. I also try to overthink it because you're right. Osteoarthritis is like he's a kid. Why would that have
Yes,
a? I try to
I
over.
was sure about those options, but I was a bit confused in these two,
Yeah,
like
I think so.
radiculopathy. But it was stupid mistake. Radiculopathy has sensory involvement.
Yeah, and we all know that the vascular necrosis, the steroid, all of the sickle cells,
Sickle
they
cell,
cause
yes, they have
sickle
given a clue.
steroid.
Sickle
Yeah,
cell.
they
Why
cause
I
a
put
vascular necrosis. But osteoarthritis, I thought because they kept saying that he keeps having dactylitis, and so he keeps having inflammation symptoms. So maybe too much inflammation led to I don't know. Just I was started overthinking it. Yeah, that's why I don't know.
okay.
And
Next,
that's fine.
overthinking is bad.
It's bad. Can we take like a 5 minute break?
Yes, yes.
Okay. Okay. Thank
67-year-old woman is brought to the 67-year-old woman is brought to the emergency department 24 hours after a sudden onset double vision pain behind the right eye and mild nausea. She describes her double vision as seeing objects side by side. She has hypertension, type 2 diabetes mellitus, peripheral neuropathy, and chronic renal insufficiency. Medication include fosinapril and glyburide. Vital signs are within normal limit. On examination, her double vision is most pronounced when she looks at her right. If she covers her, if she covers either eye, the double vision resolves. If she covers either eye, her double vision resolves. The pupils are 3 mm and minimally reactive to light. When the patient looks at the right, her right eye does not abduct. Achilles reflex are absent. Sensation to pinprick and decreased in a stocking distribution over the feet. MRI of the brain show which of the following.
you. Between ready.
Yes,
Okay. So is normal findings. The abducent nerve exits the brainstem ventrally at the pontomedullary junction and innervates the lateral rectus medius muscle of the eye. Most common causes of acute abducens nerve passes in adults include microvascular ischemia, Secondary to diabetes, hypertension, atherosclerotic vascular disease, idiopathic causes, and trauma. The abducens nerve is fragile and vulnerable to injury as it crosses the clivus by mechanism causing downward traction. Abducens nerve palsy presents with binocular horizontal diplopia and ipsilateral abduction deficit of the affected eye. Diagnosis is made on clinical exam, and often there is no definitive finding on MRI. Treatment includes systemic workup for vasculopathic risk factors and patching to reduce diplopia. Abducens nerve palsy secondary to microvascular disease may resolve spontaneously after several months. Orbital tumor will be unlikely to result in abducens nerve palsy. It will more likely directly affect ipsilateral or straocular muscle through local mass effect. Okay, next.
Subduction nerve palsy, binocular horizontal diplopia, vision, and ipsilateral abduction defect. Okay,
I think the key here is his diabetes is the thing that caused the abductor nerve problem.
okay. A 32-year-old woman is brought to the emergency department. 32-year-old woman is brought to the emergency department 3 hours after the onset of confusion. She appears agitated. She mistakes the attending physician for her brother and insists he call their he call their father. She admits to drinking regularly since the age 22 years. Her last drink was 4 ounces of vodka 72 hours ago. Her pulse is 110 per minute, blood pressure is 170 by 110. Physical examination shows ataxia and a 3 cycle per second. Bilateral hand tremor on mental status examination. She is oriented to person but not the place and time. After the examination, she yells, I saw dad there. Why didn't you tell me? He was coming to pay my bail. I could be out by now. Which of the following is the most likely diagnosis?
Ready?
Okay.
With delirium tremors, alcohol increases the CNS activity of GABA inhibitory neurotransmitter. Abrupt discontinuation of alcohol leads to sympathetic excess. Uncomplicated alcohol withdrawal typically presents with tremors, anxiety, restless, headache, nausea, diaphoresis, which can occur hours after cessation of alcohol. If left untreated, alcohol withdrawal can be complicated by seizures, alcoholic hallucinosis, auditory and visual hallucinations. Delirium tremens is the most concerning and life-threatening complication. Or alcohol withdrawal typically begin like 2 days to a week after the patient has drink. Presentation of delirium tremens includes severe confusion, disorientation, fluctuations in consciousness, agitation, visual, auditory hallucination, autonomic stability. All withdrawal is managed supportively with benzos to address the agitation, along with fluids, nutritional supplementation, and frequent monitoring of vital signs. Alcohol hallucinosis is characterized by visual, tactile, auditory hallucination beginning like 12 to 48 hours after the patient last drink. Patients with alcoholic hallucinosis typically have normal vital signs and remain oriented. Oh, vital signs and oriented, that's the key. Idiosyncratic alcohol
Vital
intoxication,
signs orientation and the time. Uh,
yeah,
12 to 48 hours, like within 2 days. But her last drink was 3 days ago in this patient. 72
yeah,
hours.
yeah. Idiosyncratic alcohol intoxication is a type of alcohol-induced psychosis in which ingestion of a small amount of alcohol results in aggression, belligerence, impaired consciousness, and hallucination. Okay, next.
A 24-year-old woman comes to the office because of 4-month history of generalized weakness and moderate muscle aches. Initially, she had difficulty standing after she removed clothes from the dryer. Initially, she had difficulty standing after she removed clothes from her dryer. Now she has difficulty waking up stairs and rising from chair. She has no history of serious illness, takes no medication. Her mother has rheumatoid arthritis. Imaging shows periorbital purplish discoloration bilaterally. Cranial nerves are intact. Palpation of the muscles produce pain. Muscles and 4 by 5 in the deltoid, biceps, hip flexor, quadriceps bilaterally. The results does not change with repeat testing. Muscle bulk tone normal bilaterally. Deep tendon reflex 2 plus and the brachial radialis. Muscles and ankles are 1 plus in the biceps and the quadriceps. Sensation is intact throughout. Which of the following is the most likely diagnosis?
Jesus.
Dermatomyositis polymyositis is proximal myopathy, isn't it?
Yeah, it sounds like I would say dermatomyositis, but she doesn't have, I guess, the periorbital. I don't know if that's a.
Purple, periorbital purplish discoloration bilaterally.
Is that one of the dermatomyositis signs? I know the Gottron papules, but I never
I
heard
don't
of.
think so. And
You don't think?
dermatomyositis polymyositis is proximal muscle should be weakened, isn't it?
Yeah, she
Proximal
has
muscle 4 by
she
5.
she has proximal muscle weakness. The deltoid, the biceps, or other are proximal, and then the hip proximal too.
But muscle strength is 4 by 5.
4 by 5 is low, right?
No, it's kind of normal.
Oh,
4 by 5
oh,
is normal, isn't it?
I thought normal was 5 by 5.
If I test your muscle strength, it would be 4 by 5. It is
Oh,
normal. Like examiner, like I think so. Like
okay. So what do
strength
you
is
think?
uh 4 by 5, 5 by 5 is kinda.
So what do you think it is?
That is the most confusing part. Simple
Well,
answer is dermatomyositis. If we think simply, because purplish discoloration bilaterally, but
I don't know what the purpose discolor. We know it's not myasthenia gravis because they specifically say even if you continue, blah
and
blah blah. There is
Charcot-Marie tooth disease comes with food problem like pes cabas and these and that.
oh yeah, I forgot that one. I don't remember what it was. And inclusion body myos. I don't know what's inclusion body myositis. I really don't know what it
Okay,
is.
let's go with
Let's see.
normal.
So it's dermatomyositis. Yeah, 4 by 5 is not normal. It's
Okay.
decreased. Dermatomyositis is inflammatory condition that
Usually,
affects.
when we see the muscle strength of the patient, 4 by 5 is considered as normal. Okay, so 4 by 5 is not normal.
Dermatomyositis is I feel like in real life, yeah, you wouldn't put the patient on medication because he has 4 by 5, like probably. But yeah, on the exam, yeah, yeah. But in real life, not that you're saying it, yeah, I probably had like 4 by 5 patients and they weren't. It wasn't a problem. Yeah. Dermatomyositis, inflammatory condition that affects both skin and MSK system. Cutaneous finding of dermatomyositis include heliotrope rash involving the periocular. Oh, that's what they call. Okay. Involving the periocular area, bottom papules overlying the joints and dorsal of the hem, polio, poikilodermatous rash distributed over the shoulder and chest on upper torso. MSK include proximal muscle weakness, especially the deltoid, blah, blah, blah. Difficulty rising to stand or lifting the arms over the shoulders. Diagnosis is made clinical, and serologic testing include antinuclear, anti-Jo1, anti-SRP, anti-MI2, along with serum CK assay. Patient diagnosed with dermatomyositis should undergo further workup for age, including age-appropriate cancer screening to rule out underlying occult malignancy, although malignancy is less common in young patients. It's not Charcot-Marie-Tooth genetic disorder that presents with slowly progressive peripheral neuropathy, often in association with foot deformities such as hammer toes or pace cavers. It is commonly inherited and autosomal dominant. Histone inclusion body myositis is idiopathic inflammatory myopathy that commonly affects all the males. Symptoms include insidious onset of proximal or distal leg weakness and dysphagia. Characteristic muscle biopsy findings include infiltration of inflammatory cells, fibrosis, inclusion body, and of vacuole seen with staining. Unlike other inflammatory myopathy, inclusion body myositis is resistant to immunosuppressive therapy. It's resistant. Okay. So it's muscle weakness with dysphagia.
So proximal muscle weakness and characteristic skin finding goes with the dermatomyositis and polymyositis, but no skin lesion. And inclusion body myositis. In inclusion body myositis, it usually involves the, what can I say? It usually involves the forearm muscle, like the distal limb muscle is involved. Forearm muscle, intrinsic hand muscle is involved in inclusion body myositis. You got it?
Mm-hmm.
Okay. Okay, let's move on to the next question. A 19-year-old man is examined in the ICU 3 days after admission for a self-inflicted gunshot wound to the head. Temperature is 30 Temperature is 37.2 degrees Celsius, pulse 88 per minute, ventilator rate 16 per minute, blood pressure 100 by 40. Pupils are non-reactive to light, corneal reflex is absent. Irrigation of the ear canals with cold water results in eye movement on toward the ear being irrigated. On application of the non-noxious stimuli, the patient has only spinal reflex. He is not initiating breaths spontaneously above the ventilator. Which of the following findings prevents a diagnosis of brain death in this patient? Prevents a diagnosis.
Hmm. I'll be so pissed if I miss this. I just read about this.
Which of,
Ready?
which of the following finding prevents a diagnosis of brain death? Prevents.
I must get this right. I just read this in
Okay.
Euro. This should be yes. The diagnosis of brain death is determined by the presence of three factors: absence of brainstem reflex, persistent coma, and lack of spontaneous respiration. Commonly tested brainstem reflexes include pupillary right reflex, the corneal reflex, and the pharyngeal and tracheal reflex, which include the glossopharyngeal and vagus cranial nerve by observing the gag reflex of the coughing one. The oculocephalic reflex, which takes oculomotor, abducens, and vestibulocochlear nerve by assessing for ocular movement during head turn. Normal response is eye movement away from the direction of the head turn, whereas an abnormal response is characterized by eye movement with the direction of the head turn or fixed at midline, and the vestibulocochlear reflex. Caloric stimulation will test the vestibulocochlear reflex, test the oculomotor abducens and vestibulocochlear cranial nerve by assessing for an oculomotor response to irrigation of cold water into one of the ear canals. Cold water irrigation decreases the rate of vestibular afferent signaling within the affected vestibular apparatus, simulating a head turn to the contralateral side. A normal response to cold water irrigation involves tonic deviation toward the ipsilateral ear and horizontal fast nystagmus towards the opposite ear. The fast pace of nystagmus receives input from the dorsal stream of occipitomotor cortex. Absence of fast-phase nystagmus suggests an absence of cortical function, whereas absence of slow tonic deviation indicates absence of brainstem functioning. Absence of both components of caloric test is required for the diagnosis of brain death. This patient caloric testing, which demonstrates low tonic deviation toward the side of cold irrigation, may prevent the diagnosis of brain death. Did not understand this, but yeah. Mm, you got it?
Mm, on caloric irrigation of the ear canals with cold water results in eye movement only toward the ear being irrigated, like in the patient is alive or not. We see via this caloric test. We put water into the ear, and if there is nystagmus, normally in normal people, if we put water into normal people, there will be nystagmus. So that means his brain is still working, so it is not brain dead. You got my point.
Okay.
According to caloric reflex, uh, which means the vestibulo-ocular reflex, which means that this patient does not have brain death, and it is seen, uh, it is it is confirmed if there is no movement after being uh, water is installed into the ear. That means his brainstem reflex is lost on on that aspect.
Okay.
You got it?
Got it.
Very
Next.
complex thing this is.
I don't think you needed that explanation for this question. This question is basically saying, it's telling you already in the question, choreal reflex he doesn't have, leg reflex he doesn't have, respiratory effort he's not able to breathe, motor response he's in the ICU, of course he's not moving. So the only thing left is the caloric response because
For diagnosis of the brain death,
yeah, for diagnosis of the brain death, basically all the reflex.
for the diagnosis of the brain death, we need all the brainstem reflex should be absent, like
Yeah.
pupillary, corneal, oculocephalic, or oculovestibular. This one is oculocephalic or oculovestibular.
So yeah, that's what I'm saying. They already told you the cornea is absent. They already told you the right reflex is absent. They already told you respiratory effort is gone because he's not able to breathe on his own. So the only one you have left is the caloric response.
Yes,
And they're telling you here the caloric response, blah blah blah, moving. The eye is still moving. It doesn't matter if you know what side is moving or not, but it's moving. So something, yeah, it's still working. His caloric response.
But
So
if
that's why
we see the plantar, is it absent or present?
it doesn't. They didn't tell you anything about plantar
No,
here.
no, I am telling you, like if you do plantar reflex on a dead patient, what will happen?
I don't know. I think for the I know what I read it was they were saying for the not these reflexes, not the brain ones. The one for the knee, the patella may still be present. That's why we you don't use those because in a dead patient, the patellar one, whatever, it takes time to go away. So
Yes,
that's why you don't use them.
the deep tendon reflex,
Mhm.
which
That's
is
why you don't use them.
originating from the spinal cord,
Mhm.
these may
Yeah,
be still
yeah.
present.
That's why you don't use them to for the diagnosis of brain dead. You use the those ones, the light and the corneal. So
Okay.
even here, even if they were telling you here the plantar reflex is still blah 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 blah, blah, that wouldn't be the answer.
Yes.
You see what I'm? Mhm.
Okay. A 4-year-old boy is brought to the physician predominant because he walks predominantly on his toes. He was born 29 weeks of gestation. Has he has a history of hyaline membrane disease and a grade 1 interventricular hemorrhage. He takes albuterol for asthma and his immunizations are up to date. He set up at the age of 9 months and walked at 18 months. He currently uses full sentences when talking. He is at 50 percentile for both height and weight. Examination shows generalized hyperreflexia and a persistent Babinski sign bilaterally, heel cord contracture and decreased abduction and external rotation of the hips. Which of the following is the most likely diagnosis? He currently uses
Ready?
wait 1 second. Yes.
The cerebral palsy. Here you could have just used the delete all the other things to get to the answer. Cerebral palsy is a disorder of non-progressive central motor dysfunction as a result of impaired fetal and neonatal brain development. Non-progressive central motor dysfunction. The cause is frequently multifactorial, though the most important factors are premature delivery, which may increase the risk of cerebral palsy, and low birth weight. Patients who are born prematurely may also have experience may also may have also experienced other sequelae of prematurity, including hyaline membrane disease, bronchopulmonary dysplasia, intraventricular hemorrhage, mm, intraventricular, necrolytic enterocolitis, retinopathy of prematurity. Other risk factors include intrauterine infections, antepartum hemorrhage, placental pathology, multiple pregnancy, heavy maternal alcohol use, maternal smoking, maternal obesity. Cerebral palsy typically presents with open motor neuron signs, spasticity, peripheral Babinski. Dyskinesia, ataxia. Diagnosis includes throughout history and physical exam along with MRI. Management requires an interdisciplinary team to support the patient daily function.
Next. A 42-year-old woman comes to the office because of 2 month history of generalized weakness. During this period, she has difficulties climbing one flight of stairs or combing her hair. She also reports double vision that occurs when she reads. She has no history of serious illness, take no medication. Examination show bilateral ptosis, muscle strength 4 by 5, deep tendon reflex 2 plus. Which of the following is the most appropriate next step in the management? Ready?
Yes. It is repetitive nerve stimulation. This patient presented findings of intermittent ptosis, diplopia, proximal muscle weakness are suggestive of myasthenia gravis. Myasthenia gravis is a B-cell-driven autoimmune disorder characterized by formation of an inhibitory acetylcholine receptor antibodies. Patients typically present with muscular weakness and fatigue that worsens toward the end of the day, as well as ocular symptoms of ptosis diplopia. Many patients present with ocular findings and later develop the generalized involving symptoms involving the muscle, the proximal muscles. Um, Several tests can help support the diagnosis of myasthenia, including the ice pack test, improvement of ptosis after placement of ice pack on the eyelids for 2 minutes. The hydrophonium test, improvement of muscle strength after administration of acetylcholinesterase inhibitor, and repetitive nerve stimulation study. In this type of study, the motor nerve is repetitively stimulated and the compound muscle action potential is recorded after each stimulation. In patients with myasthenia gravis, there is decrease in each compound muscle action potential amplitude after the first stimulation. Diagnosis of myasthenia gravis is confirmed with detection of serum autoantibodies in addition to positive repetitive nerve stimulation study. Next.
Next. A 37-year-old man comes. A 37-year-old man comes to the physician because of 3 week history of joint pain. The symptoms initially begin with increasing pain in his left knee, and has progressed
Wait,
to
wait, which one are you reading?
47.
Oh, never mind. There are 246. Okay, sorry. Yeah, go ahead.
A 37-year-old man comes to the physician because of 3 week history of joint pain. The symptoms initially begin with increasing pain in his left knee, to has progressed to include right knee and left hip. There is no history of trauma. 6 weeks ago, he had fever, malaise, 5 centimeter rash in the central clearing. 5 centimeter rash with central clearing. Sorry, 5 centimeter rash with central clearing on his chest resolved spontaneously after 7 days. He is sexually active with multiple partner and uses condoms inconsistently. His mother. His temperature is 37.1 degrees Celsius, blood pressure 148 by 90. Examination of the left knee shows no warmth, rhythm, range of motion of the left knee is full and do not produce pain. Range of motion of the right knee is limited by the pain. There is moderate joint effusion, abduction, adduction of the left hip against resistance produce pain. Which of the following is most likely diagnosis?
Oh, Jesus. Is it gonococcal or is it Lyme? He
There
said
is
that
5 centimeter rash with central clearing.
central clearing.
Lyme
That goes
disease.
to Lyme. But then he has sexually partners inconsistent and all that.
But diffuse gonococcal arthritis, there is DGI, like tenosynovitis. There may be arthritis, and there may be skin rash also. Maculopapular skin rash.
But you don't think it's gonococcal, you think it's Lyme.
Yes, I am with Lyme.
Okay. Let's check. So it's Lyme. Lyme arthritis, one of several complications of Lyme disease caused by disseminated Borrelia. Borrelia are transmitted following tick bite, most commonly from ixodes tick. Um, Initial manifestation include erythema chronica migrans rash, which is a spongy rash with central ring-like clearing and targetoid appearance. It generally appears within 1 to 2 weeks of tick bite. Left untreated, a subset of patients will develop disseminated disease that may result in Bell's palsy, meningitis, myopericarditis, arthritis. Patient may be diagnosed clinically when the characteristic erythema migrans is observed. Serologic testing is controversial as it may show false positive or negative. However, it may be used to support the diagnosis. In later stage, patients with Lyme disease are treated with doxycycline and amoxicillin. Most patients with Lyme arthritis will demonstrate response to therapy. It's not gonococcal arthritis. We present with fever. Malaise and migratory polyarthritis or oligoarthritis. Patients will have purulent arthritis of one or more extremity joints. And synovial fluid analysis will show greater than a lot of leukocytes without organism.
Next.
Treatment of gonococcal IV ceftriaxone along with possible irrigation of the affected joint. So fever and purulent arthritis. Okay.
A 57-year-old man is brought to the emergency department because of 24-hour history of progressive agitation and confusion. She has used a wheelchair. He has used a wheelchair since an accidental gunshot transected his spine at T9 level 20 years ago. On arrival, there is too much to provide: his medical history, his medical records, that his medications are pregabalin for neuropathic pain, diazepam for spasm as needed. His family reports that he does not drink alcohol or illicit drugs. He appears well nourished, he is uncooperative, and hits anyone who touches him. His temperature 101.4 degree Fahrenheit, pulse 106 Fahrenheit, blood pressure 110 by 76. Physical examination shows paraplegia. He is oriented to person but believes he is at home. He appears to be responding to internal stimuli. Leukocyte count 22,000, nitrate positive, leukocyte ester positive, bacterial more than 10,000. CT scan show no abnormality. In addition to administration of the antibiotic, which of the following is the most appropriate pharmacotherapy?
Ready? Ready?
Yes.
Okay. So it's alloperidol, damn it. Um, Delirium is defined as by acute onset alteration of conscious and cognition with symptoms that wax and wane through the day. In elderly patients, especially those with underlying dementia, system, blah, 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 delirium can develop rapidly. Other common causes of delirium include intoxication and adverse effects from medications such as anticholinergic, benzos, and opiates. All patients with delirium should be evaluated for evidence of systemic infection with analysis in culture, checks, X-ray, and occasionally blood cultures. If indicated. Treatment of delirium should focus on treatment of the underlying infection if one is detected, frequent reorientation and maintenance of normal sleep-wake cycles, and placement of patient in a calm, soothing environment. Well, patients with refractory symptom antipsychotic therapy may be used, including haloperidol. Diazepam and midazolam are benzos commonly used for treatment of seizure disorders, sedation, anxiety, and muscle spasm. Benzos bind to GABA receptors and increase the frequency of their opening. GABA is inhibitory neurotransmitter that counterbalances neuronal excitation, making benzos an effective treatment for seizure. Benzos are known Trigger for delirium and susceptibility patients are not recommended to treatment of delirium. Okay, got it. Next.
A 27-year-old woman comes to the physician because of 3 week history of headache that are dull, constant, and localized to the back of her head. The pain is not relieved by ibuprofen. She has not had fever, nausea, vomiting, weakness. She has 5 year history of AIDS, currently treated with 3 drug antiretroviral therapy. Her temperature is 100, pulse 90, respiration 14 per minute. Blood pressure 130 by 90. Examination show multiple 1 centimeter cervical nodes that are mildly tender. There is no papillary edema. Examination of the oropharynx show thrush. Neurologic examination shows no focal findings. Her CD40 lymphocyte is 25 millimeter. Plasma viral is 5,000 copies per ml. CT scan shows 5 1 to 2 centimeter ring enhancing lesion. Which of the following is the most likely diagnosis?
Ready? Hmm. Don't make that much
Ready?
sense. Yeah, so it's toxoplasma. This patient has AIDS with low CD4 count, CT scan during enhancing lesion, which is suggestive of cerebral toxoplasmosis. Cerebral toxoplasmosis, AIDS-defining illness caused by toxoplasma, is the most common cause of multiple ring enhancing lesion in CT scan in patients with AIDS. Transmission can occur through ingestion of oocyte from soil, cat feces, from soil contaminated with cat feces or infected meat, direct transmission from mother to fetus, or organ transplantation, which leads to invasion followed by dissemination of parasites, where it typically remains dormant. Ubiquitous organism. Um, the parasite doesn't cause problem in immunocompetent individuals. Patients with HIV and CD4 count less than 100, however, reactivation can occur with several distinct clinical syndromes, with cerebral toxoplasmosis being the worst one. Cerebral toxoplasmosis typically presents with multiple ring enhancing lesions scattered throughout the brain, seizures, focal neurologic deficits, systemic symptoms are common as signs of increased intracranial pressure. Patients with HIV and positive toxoplasma antibodies typically treated empirically with sulfonamide and pyrimethamine if cerebral toxoplasmosis is suspected, but confirmatory diagnosis occurs to brain biopsy, which will show we know. It's not Cryptococcus neoformans. CNS presents with headache, local rigidity, photophobia, and progressive encephalopathy. So meningitis and encephalopathy. CSF analysis will show an increased opening pressure, increased protein immunography. Then it has a lesions is not seen. And it's not TB. Meningitis typically presents subacute fashion with local rigidity, fever, altered status. CFF evaluation is the initial diagnostic step and will show increased opening pressure, increased white blood cell count with lymphocytes, increase protein, and decrease glucose. Okay,
Okay, okay.
next.
Next, final question. A 32-year-old man comes to the emergency department because of 2 day history of low back pain that began 4 hours after he lifted a sofa. Uh, his symptoms have gradually become worse now, as severe pain without any movement of his back. The pain radiates to the right posterior thigh. He has had no choices in the he has had no changes in the bowel and bladder. Temperature is 37 degrees Celsius. Um, Pulse 88 per minute. Respiration 18 per minute. Blood pressure 120 by 80 on examination. Flexion and extension of the waist and twisting movements of the torso increasing pain. There is tenderness over the lumbar paraspinal musculature bilaterally that is more prominent on the right, straight leg raising. Chest right causes pain in the right sacral area at 45 degree. Neurologic examination shows no abnormality. Sensation is interchangeable following is the most appropriate next step. Okay.
Ready?
Yes.
So it's ibuprofen. This patient presentation is suggestive of acute low back pain, which lasts um, with acute onset of low back pain, which lasts up to 4 weeks and may be attributed to MSK injury from exertion or use of trauma. Symptoms include pain with movement and paraspinal tenderness in the absence of neurologic or bony tenderness. Most cases resolve with conservative management, which includes activity modification, stretching, and physical therapy. Over-the-counter analgesics such as NSAIDs, massage, and heat therapy. Certain red flag signs and symptoms should prompt more urgent evaluation for alternative cause, especially if there is concern for infection, malignancy, spinal cord compromise, or vertebral fracture. These include, but are not limited to, fevers, in IV drug use, focal neurologic deficits, progressive lower extremity neurologic symptoms, current or recent cancer history, advanced age, systemic steroid use, and significant traumatic mechanism. In this young, otherwise healthy patient, mild setting event, the most appropriate is ibuprofen therapy. Okay, we are done.
Okay.
I will see you tomorrow.
Okay. Neuro 8.
Yeah, Neuro 8. That's the
Okay.
last one.
Bye bye.
Bye bye.